Excellent. And who we have for you today to present is Dr. Nate or Nathaniel Sharon. He is a child and adult psychiatrist at UNM, and he primarily works with transgender populations and people with HIV. He's also the child psychiatrist at the School-Based Health Center at Truman High School and the co-director of transgender services at I'm sorry, did I say Truman High School twice? Correct, Highland. So he's a child psychiatrist at the School-Based Health Center at Highland, but the co-director of transgender services at Truman High School. He's a very busy individual, it looks like. So as you recall, for those who participated in the fall series, we had Dr. Rosenthal give an amazing presentation to introduce the topic of working with transgender youth. So in our spring session, as we focus on behavioral health, Dr. Sharon will be talking about behavioral health's role in supporting the health of transgender and gender non-binary youth. So with that, I will give it over to Dr. Sharon, and we'll get started.
Thanks so much for the intro, and I'm really excited to give this talk. I really appreciate all of you guys tuning in. I see some familiar people, and I'm really excited to connect with people and increase knowledge about how behavioral health can really support the outcomes of these youth. I want to really encourage people to ask questions throughout the talk, in part because I know Dr. Rosenthal laid down some great fund of knowledge and some medical knowledge about how to take care of these youth. So I'm starting off at a little higher level and assuming that most people have kind of a basic 101 knowledge of trans and gender non-binary youth. But today we'll break down a little bit of that holy triad of endocrine, pediatrics, and behavioral health that work with this particular population. So some clinical questions I frequently encounter from pediatrics is something along the lines of, I have this adolescent patient who came out as this particular gender. They want to start this particular hormone. What do I do next, and how can you help me? And then another very common question I get is, you know, this kid walks into my office. I'm pretty sure this is a slam dunk case for this kid to start hormones. What do I need to do next, and how do I refer? And I think oftentimes pediatricians think about behavioral health for this population specific to hormones, but we're going to unpack the role of behavioral health as a little bit more in depth and broader. But specifically, behavioral health is needed for a couple different reasons. One, behavioral health is required by standards of care specific to recommendations for physical interventions for gender dysphoria. So standards of care for treatment of gender dysphoria and these adolescents are put out by the World Professional Association for Transgender Health, otherwise known as WPATH, and the Endocrine Society guidelines, which hopefully Dr. Rosenthal reviewed a little bit at his talk. But basically, both these standards of care maintain that any youth seeking hormone or physical interventions to treat gender dysphoria must be assessed by behavioral health first. That is really specifically different from the adult transgender population, where the standards of care say, yeah, behavioral health could be helpful, but not necessarily needed. For adolescents wanting to start hormone therapy, the standards of care say behavioral health must assess that youth prior to a medical provider launching in on physical interventions. And both standards of care also strongly recommend that behavioral health be involved in supporting this youth and their system, regardless of if they're going to be pursuing physical interventions or not, just due to the chronic external stressors that these youth face, with discrimination, family rejection, stressors at school, and during transition and treatment for gender dysphoria, they also recommend ongoing behavioral health involvement just to support youth during their gender transition. Because even though it can be a positive thing for a lot of kids, it can also, the gender transition can cause a lot of stressors as well. So that's generally why behavioral health is involved. If we also just look at co-occurring mental health conditions in this population, they just have higher rates of PTSD, depression, anxiety, self-harm behaviors, and suicide attempts compared to their non-transgender peers, and even compared to their lesbian, gay, or sexual diverse peers. And these higher rates of mental health problems are more than likely correlated, we think, with their increased environmental stressors, particularly family rejection and bullying and mistreatment at school. We also see a very interesting phenomenon. There's a lot of more data out on this now of an increased incidence of autistic spectrum disorders in trans and gender nonconforming youth that present to clinics with gender dysphoria. We also see the opposite. Patients going to clinics for autism also have show about the same rates of gender diversity in that population. So in kiddos that have been diagnosed with gender dysphoria, we see about a 7 to 8% occurrence of autistic spectrum. And then if you just look at traits of autism, or level 1 in particular, formerly known as Asperger's, you see much, much higher incidence of even autistic traits in 23% of the youth presenting for gender services. And I would say clinically, this is really held true. And all the populations that I serve, and I have taken care of gender diverse people from the age of 2 to 70, and I see high amounts of what I would call neurodiversity in this population. And in terms of just risk behaviors that increase poor health outcomes, we see increase high risk sex behaviors, substance use, increase rates of HIV beginning in adulthood, and that's really particular with transgender women of color who have around about 30% incidence of HIV in that population, and very, very high rates of trauma experiences. And of course, if all y'all are familiar with the ACE study, or the Adverse Childhood Event Study, we know that all these adverse events that add up over time increase the odds that these youth are going to have poor mental health and medical health outcomes as they get older. There's been some protective factors that I think are important to identify in this youth in terms of their strength and things that can help support them for really good outcomes. This primarily includes family or caregiver acceptance. And this is probably the most highly correlated one with as a protective factor. And when you don't have it, the highest correlation for suicide attempts, depression, and anxiety. The other protective factor is a positive school environment, and particularly if that school has a GSA or Gay Student Alliance or some type of positive queer student organization at school has been shown to really keep these kids safe. But they have a lot of high incidence of school bullying by staff and peers, and then early school dropout because of that. So just to go back on this first behavioral health slide, you know, behavioral health is really important when coordinating care specific to gender dysphoria in this youth. But as you can see, behavioral health can also be super, super helpful in this youth just because of their increased risks of mental health problems due to the stressors that they face. So referrals can occur at different stages. And I know this is adolescent specific, but I did want to touch a little bit on prepubertal children and why you would refer to behavioral health. You can often see when prepubertal children present, if they're presenting in distress specific to gender, it's often external related, internal related, or a little bit of both. So you can see a kiddo in distress related to extremely invalidating environments, such as dad forcing the kid to cut their hair every time and the kid has a massive temper meltdown, or the kid's refusing to go to school because the parent continues to insist that they wear a dress to school, but the child's mortified for wearing a dress. And behavioral health has a huge role in depathologizing and normalizing gender diversity for caregiving systems, and to help to reduce the external environmental factors that are leading to distress. But children before puberty can also present in distress over their gender. In terms of specifically in distress regarding incongruence about their body not matching their gender, or they're just in distress over not being recognized or seen as their affirmed gender. So I do evaluate some children before puberty for specifically to gender dysphoria. In the peripubertal and pubertal period, referrals for behavioral health can occur for a couple different reasons. Again, the same external distress I mentioned about environmental factors can always be present, and kids can present in distress over those. But then around peripubertal time, even before Tanner 2 starts, the very beginning of puberty, you can start to see an increasing distress related to pending pubertal changes. So I'll commonly see 10, 11-year-old kids in my office, and they've been talking about sex ed in 5th grade, or their parents are starting to tell them a little bit more about pending puberty, and they are starting to freak out. This can also happen to kids where parents have already, quote unquote, socially transitioned their child. So say since age 5, you've got a natal male who's living as female, and everything's going golden, but then that kid is anticipating male sex changes for puberty, and then that's when they start to have those suicide attempts, cutting behaviors, and start to have meltdowns. So the peripubertal period is actually, to me, even more critical to start screening for and looking for those referrals to behavioral health, specifically if there's increase in gender dysphoria. And finally, with the onset of puberty, again, external distressors, but also the increasing distress related to starting Tanner 2 pubertal changes or existing sex traits. And this is commonly a time where pediatrics and endocrine will refer for a behavioral health assessment for that kid trying to seek either puberty blockers or hormone therapies for gender dysphoria. So that's just kind of like a breakdown of along each sort of developmental stage why you might think about referring to behavioral health. So just to give you an idea of when you're referring to behavioral health, some ethical guidelines of referrals to behavioral health providers and what type of provider you're going to want to refer to. If you refer a kid out to a behavioral health provider who thinks as gender diversity as pathological or performs conversion therapies, that will likely be considered a poor referral and could end up hurting the kid. So just thinking about when behavioral health is working with these youth, these are some of the ethical guidelines that they should follow. And it's really called the gender affirming model. I'm sorry I didn't put the reference. This is by Hidalgo in 2012. But the gender affirming model are these ethical sort of guidelines or bumpers, if you will, to help keep a behavioral health provider sort of the right alley for caring for these youth. And the first and foremost stance is that behavioral health provider is there to support the gender development of the child by really giving that child autonomy over their gender development. And that behavioral health provider shouldn't really have any a priori outcomes for that child's gender development. That provider should not try to steer that youth's course towards being transgender, towards being cisgender, towards being any gender, but to really support that child and follow that child's lead. Also, the behavioral health provider should have a non-pathological view of gender differences within gender development. Gender differences within gender development are not pathologies, they're not mental illnesses. And a gender diverse kid is just as normal within their gender development as any other kid. They should really have a stance of trying to reduce the sequelae of the social gender discrimination that a lot of these youth face. So a lot of behavioral health providers are often also advocates for the kid. And really the goal should be supporting all aspects of the child's development, including social, emotional, cognitive, sexual, and gender development. And within gender development, making sure that all these other areas of development are being met, and that the diversity of the gender development and the problems with that aren't impacting other areas of development. The provider should really work on increasing protective factors and taking a strength-based approach for the child and the child's system. And again, no reparative or quote-unquote conversion therapies. Conversion therapies, I do put in quotes because they're not, that's a frequent colloquial used term, but they're not actually evidence-based practice therapies. But these are therapies that purposefully work towards altering sexual orientation or gender identity or gender expressions towards a norm, and these therapies are considered harmful and unethical. Several states throughout the United States, you can lose your license for practicing conversion therapies. And SAMHSA last year issued a statement condemning conversion therapies, and my organization, the American Academy of Child Adolescent Psychiatry, has a draft policy statement out on conversion therapies that will hopefully be released within the month. I want to emphasize, some behavioral health providers get scared when they hear about conversion therapies. Conversion therapies doesn't mean that if a youth's coming in questioning or wanting to explore what it means to be heterosexual or asexual or non-binary, that provider can't help that youth explore that path. What it does mean, though, is that there shouldn't be any forced path direction for that youth. So specifically, behavioral health's role in care can be multifold, and the roles in care are actually delineated out by the WPATH standards of care, and they can be really helpful document to turn to if you want to just review, gosh, if a trans youth comes in, what are some highlights I need to work on? Of course, there's always assessing specifically for gender dysphoria, and not all trans and gender non-binary youth that come into your office are going to have gender dysphoria or be there for that as their primary complaint or issue for care. But certainly referring for necessary physical interventions and providing collaborative care with their care system is important. I think a huge thing, and I would probably put the biggest asterisk to this third bullet, provide family counseling support. As a child psychiatrist, I don't have time to do this as often as I like. It is down and dirty work, but that is often the bulk of the work due to a lot of family questions, family rejection, families really struggling with how to support their kids. And so often as a child psychiatrist, I have to refer out to that. But I would say this is an immense skill set, the family counseling part. And I would also just let behavioral health providers know to be thoughtful about how many cases they take on that do require family counseling, just because these cases can be really intense and require some fancy footwork. So just to be mindful how many cases you take on for those. They can really help to relieve family and other psychosocial difficulties related to a youth being trans or gender non-binary. And again, that was kind of the advocacy piece as well as education piece. Of course, address and treat any mental health concerns and incorporate those concerns into the treatment plan. Trans and gender non-binary youth, of course, have more PTSD, depression, anxiety because of the trauma they face, but they also just have brains like any other human where they can have mental health problems like bipolar disorder, like generalized anxiety disorder or social phobia or substance use disorders. So it's certainly, you can treat those. Educate and advocacy for the family and other community systems. I end up often calling schools or working with CYFD or working with the legal system as needed for advocacy and education. And then also being able to rely on community supports if you got them out there, referring to any community-based support groups or youth groups. We have several here in Albuquerque. Although sometimes this could be limited, I would say there's a lot of fierce parents out there that are starting groups up in certain areas. And I just even talked to a fierce parent based out of Denver, Colorado, and they've got some groups as far-reaching as Durango. I'll not spend a huge time on this slide in terms of just the core competencies, but WPATH does mandate that there's some basic competencies met for behavioral health providers with working with transgender youth. And I would emphasize to the behavioral health people in the audience that if you don't have experience, but you're working in a rural area or a limited resource area, rather than turn that youth away and make them travel 5 hours to see someone who's an expert, I would really encourage people to increase their education, consult before turning a youth away just because this isn't your area of expertise. If you see one youth, you're going to see 5 more. And if you have to keep turning them away, eventually that's going to really hurt youth who need access to behavioral health people. So I would really encourage you, even though you may not feel super confident in working with transgender and gender non-binary youth and helping them explore their gender path, continuing to increase your knowledge so that you can do so. But certainly everyone working with these youths needs to have a master's level training or higher. And of course, trained in assessment, diagnosis, being able to use the DSM, and specifically related to children and child development. I think this is a big one, the ability to diagnose other mental health concerns and distinguish them from gender dysphoria. And this is tricky for myself. This is tricky for a lot of behavioral health providers in terms of where is this distress coming from? And oftentimes there's a good deal of distress coming from environmental factors, but there's also could be a good deal of distress coming from gender dysphoria. Sometimes it's hard to know, gosh, is this underlying co-occurring major depression as well as gender dysphoria? Do we treat the gender dysphoria first and then the depression gets better? And I think those things are really hard to tease apart, and a behavioral health provider really needs to spend time and slow it down. And I'll just ask some questions to try to tease those out a little bit. Certainly some supervision or training in psychotherapy is helpful, specifically if you're going to be engaged in weekly psychotherapy or family therapy. A good knowledge about gender differences and the ability to assess for gender dysphoria. And again, this is emphasized because gender dysphoria can be pathological. It can lead to significant morbidity, mortality, distress. Gender diversity is not pathological. So it's really important to help both the youth and the family system distinguish between, gosh, this is this beautiful, gender creative, awesome kid. There's nothing wrong with the gender. And could there be gender dysphoria where there's distress over this incongruence? And I think another key component for a behavioral health provider is continuing education, supervision, and consultation when needed. I would say bonuses would be staying up to date on transgender legal and medical policies, rights, and evolving cultural gender norms. There's this huge documentary out, The Gender Revolution with Katie Couric, and it was on National Geographic. There's just a lot more happening in the public forum regarding trans and gender non-binary youth and adults, and what happens on the national platform, what happens on the legal platform impacts trans and gender binaries' mental health. So for example, if in our state of New Mexico, a trans youth can't play on the sport team of their affirmed gender unless their gender marker on their birth certificate's changed. Well, they can't change their gender marker on their birth certificate unless they get surgery, and that's per New Mexico law. So basically, and surgeries aren't really even allowed for minors. So that basically prohibits trans minors from being able to participate in extracurricular activities within the school system. So that's something important to know and something that can really impact a child in their school system. So I really try to stay up to date on all that's going on within the community so that I can continue to empower and advocate for the youth. I think also a really good
Hi, everybody. I'm not sure if anyone can hear me. I am broadcasting on my own computer, the monitoring computer. It looks like our main one has frozen up on us. Oh, baby, what you doing here?
Does your allow you to just chat so they know we're just taking time out?
Okay, so they can hear us. So we could potentially finish up on my laptop. That might be the, well.
Or the other thing too is Dr. Karen, do you feel comfortable knowing your subject well, just talking? They have access to the slides. So as long as they can hear you.
If I just need a slide for my cue of my talking.
I can pull it up on my laptop if that would be acceptable.
Yeah. Kevin, I can go.
Yeah, we could have her print it off.
Yeah.
Sure. Sorry, everybody. We're trying to
Now
figure
we're
it
gonna do what
out.
Anderson says, the plain old phone.
That's right. Through a computer. All right. So for those of you who can't hear us, before. Okay. So I'm going to give you this guy.
Thank you.
Michelle's gonna bring
Here.
Oh, thank you.
So for those of you who can hear us, we're going to continue in just a couple moments. We're getting set up to where we can, Dr. Sharon can have access to his slides, and we will continue in just a moment.
So feel free to go ahead and get back started. Basically, we're going to be going audio only.
Okay.
So we have a printout coming?
Yes.
Okay.
So just to let you know, since the network is frozen, this will be audio only and the good old phones. So please let us know. Can chat in if you're unable to hear us or if you're having issues through audio.
Okay. I think I'll just rewind just a little bit on that last talk point of behavioral health people having some knowledge of the physical interventions and the risks and benefits, because you're part of that informed consent process with the endocrinologist and with the pediatrician. I would say endocrine and peds can often provide medical risks, benefits, alternatives of these physical interventions of puberty blockers of hormones. Where behavioral health can kind of come in is really reviewing with the family and with the youth some of the social risks, benefits. Appreciate it. Some of the social risks and benefits of the initiation of physical interventions. In particular, because when you start these physical interventions, particularly the masculizing or feminizing hormones, they lose sort of control or autonomy in that coming out process. For sexual diverse youth, they don't necessarily have to come out as a sexual diverse person. But when your body starts to change physically with either feminizing or masculizing traits, that is very hard to hide. And so really behavioral health, when a youth is exploring these interventions, really reviewing, hey, what's the plan for school? What's the plan for home? What's the plan for church? What's the plan for extended family members in terms of coming out and in terms of you physically changing? And this can be, sometimes we need to slow down the process before initiating hormones because of this aspect of the informed consent. And maybe mom really needs help working with, gosh, how are we going to come out to grandmom about this? She's going to be struggling. She may not want to come over to the house anymore. Or maybe parents are concerned about losing their place of worship because they're fearful that they won't be able to attend anymore. So really slowing down the informed consent process and thinking over all these social risks and benefits of their child changing their gender. And while the physical risks and benefits are actually quite minimal, the social risks and benefits can be complex depending on region, depending on family system, depending on religious background or cultural background. So in terms of breaking down the psychoeducation piece for behavioral health, they can be a huge role to help the pediatrician just normalize gender differences within gender development. And that includes normalizing differences of gender expression and behaviors. You might just have a beautiful gender unicorn on your hand who likes to just explore different gender behaviors and roles. But they can also help normalize development of gender different identities, in particular as gender theories are changing. And we still assign a developmental process known as gender identity at birth, which to me is almost equating assigning a sexual orientation at birth. And we base that assigned on sex at birth, but as we know, many kids develop in different gender identities than what they were assigned at birth. So really providing some normalization for that, supporting caregivers and supporting ways they can help their gender creative child. So oftentimes caregivers will go to their kid and just unload all their thoughts and feelings about their gender, about like how they feel about their gender diverse kid. And they say, whoa, not to your kid, I'll help create this space where you can come in and talk to me all about your fears, your worries, every feeling you have, both good and bad, all are valid, but I'm here to support you through those so that doesn't have to be put on your kid. Helping the caregiver and providers, giving them education about distinguishing between gender diversity, which again is non-pathological, versus gender dysphoria, which is a diagnosis. And then providing them, if there is gender dysphoria, with a lot of education about this diagnosis, what we know about it, what treatments have been effective, and what evidence we have for those treatments for gender dysphoria. And then finally, if a kid is in the process of treatment for gender dysphoria, behavioral health can play a huge role in continuing to monitor how things are going with the gender development throughout the transition process. Behavioral health can also be super helpful in education and advocacy within community systems. That includes like maybe calling up the leader of a place of worship and saying, how can we support this youth and this family at your place of worship? Working with them on getting supported in extracurricular activities. If Albuquerque Public Schools isn't going to let this kid play tennis, then what about the Y, or what about some other organization? And really, as I mentioned before, promoting those protective factors, getting that kid engaged at their school GSA, getting them engaged with any identified community supports, really increasing the bond between their family of origin or family of choice. A lot of youth I work with live or have support from a family of choice. And increasing that child's agency and problem-solving skills, which really can be protective factors against suicide. Suicide often is due to people feeling very passive in their environment and feeling like they're a burden. And so if you increase that youth's problem solving and agency to be like, hey, there's this immense difficulty or burden, but I've got these ways I can support myself, these ways I can solve my problem, and that can really help as a suicide prevention factor. So a big role for behavioral health is to assess for gender dysphoria. And I'll just review what that is. It's a DSM-5 diagnosis, and the DSM-4, it used to be known as gender identity disorder. But since 2013, it's been gender dysphoria. That effort was to remove the pathologization of, as a mental illness, gender identity, and really focus on the distress or the loss of functional impairment between one's affirmed gender and the incongruence of physical sex traits. So in childhood, that can be a dislike of incongruent sex traits, a desire for different sex traits, often can manifest with alternate gendered play behavior, but that's not always present. And in childhood, some gender dysphoria we see doesn't tend to last through adolescence, but for a very small set of kids, it can go on to persist through puberty and worsen with puberty. In adolescence, you can get new onset gender dysphoria from just the beginning of puberty. That's also an increased time in social awareness of self and other. And so kids become more cognizant or more aware that socially they're not being seen or recognized as their affirmed gender, and that becomes more important to them. Are they able to see slides or no? Or they're just hearing my voice
Not
at this point in time?
They're
Okay.
hearing your voice.
Okay.
Yeah,
They do
my
have access to your
apologies.
slides because they were able to download them.
They do, but
So-
yeah, we're having some
Okay.
sort of very,
So the next two slides were just graphics, and what I'll try to just describe on these graphics are basically the first slide is a graphic of a huge pie of trans and gender non-binary kids before puberty. And out of that huge pie of gender diverse kids, I would say a very small subset of those kids have gender dysphoria of childhood, which is that, that feeling of incongruence between body and gender. But as kids progress developmentally, both cognitively, emotionally, socially, sexually, into puberty, that pie of gender and trans and gender non-binary kids with gender dysphoria gets a lot larger. And that's where often you're going to start seeing kids first present for care.
I'm sorry, Dr. Sharon. At what age were you saying? Like pre-puberty?
Pre-puberty,
Okay.
yeah, versus basically starting of puberty,
Okay.
sexual, secondary sex traits developments. That's where a lot more kids start to manifest either new onset gender dysphoria or worsening gender dysphoria. Behavioral health is vital for the coordination of care, and they are required for the initiation of hormones. There are specific criteria needed before the initiation of hormones. That includes documentation that that child has had quote unquote long-standing gender dysphoria and a gender identity that's different than what was assigned at birth. Long-standing is very vague. So I think that can be really hard to tell. And clinically, you know, the DSM says 6 months or longer as persistent. I would say every child I meet is a snowflake. And long-standing can mean a lot of different things. And sometimes we have to slow down what it means that this has been around for a long time. Does it mean that that child's been sort of gender diverse and exploring their path for a long time? Does it mean that since age 2, they were insisting they have a penis? So it can really vary quite differently. And I think that long-standing gender dysphoria just needs to be slowed down depending on the presentation of the case. You're also, one of the criteria for starting hormones is that the gender dysphoria has worsened with the onset of secondary sex trait development or puberty. And that's pretty common for a lot of youth. And then lastly, and I starred this one, mental health and the environment is quote unquote stable enough to support interventions. And that's kind of like the readiness criteria. Like, is this child ready enough to support going through a gender transition where their mental health isn't going to so significantly decompensate that it's going to put them at risk of suicide or great harm? And is their environment supportive enough to where we're not going to put this risk at youth? You know, I may think a youth is appropriate to start testosterone, but if they're going to get kicked out that next day by their mom or get attacked by their dad for their decision, then that's not going to be a safe start, right? So we kind of have to slow that down. So we look at kind of readiness criteria when saying, yeah, youth, I think this youth is appropriate to move forward to hormonal therapy. But basically, when the mental health, social, and environmental risks don't outweigh the benefits of the intervention. And I would say for a lot of youth, once they get interventions for gender dysphoria, they feel a lot better. And oftentimes you do see a lot of externalized behaviors and internalized symptoms go down quite a bit. It doesn't mean that gender is cure for everything. And again, that's as behavioral health's role to sort out what's sort of a separate mental health issue versus what's related to gender dysphoria. But you can see a lot of mental health sequelae just kind of quiet all the way down if you treat that gender dysphoria. So oftentimes the benefits are good, but a kid's kind of swimming in the middle when you're assessing them of a lot of mental health symptoms because they're in so much distress over the gender dysphoria. There's a term in the community, in the trans community, called gatekeeping. And gatekeeping means behavioral health's traditional role in the standards of care of saying, basically being sort of like the God towards access of hormones or not hormones. And gatekeeping is a very sensitive topic and has caused a lot of mental health trauma in this community. And I would say they've removed gatekeeping requirements from adults. And as you can see, though, youth still are mandated to see behavioral health first before starting these interventions. I would say try to reframe behavioral health's role as, instead of gatekeeper, as more path paver. Like, how can we sit down with this youth and with this family system and figure out how this youth is going to thrive on all developmental planes, including gender, and what's the best way to support them in that. So rather than being like, you cut, so I'm sorry, you can't have hormones, be like, how can we support you with some increased therapy on emotional regulation and distress tolerance so we can help your cutting while we're pursuing hormones. And let's help support the bullying at school that leads you to cut so that you'll have less cutting. And maybe that bullying will go up a little bit with hormones and you transitioning. So let's talk about how you can handle that and increase your skill set. And oftentimes I see cutting behavior go down once a kid gets on the therapy for gender dysphoria. So in terms of a pathway for adolescents, basically they most frequently present to the pediatrics office. The pediatrician can provide some basic education on normalization of gender difference, maybe do some screening for gender dysphoria. If gender dysphoria is there, the youth is there, like, I'm here and I want hormones, the next step would be to refer to behavioral health, who will give you that assessment, who will say, yeah, I think this use appropriate for interventions. They've got great supportive protective factors we can proceed forward, or no, I think we need to slow it down. And then coordinating those interventions through referral to the endocrine or pediatrician. I think finally for behavioral health, one of the main things to do is to have that bird's eye view of, hey, is this child ready to move forward for treatment? And here are some reasons why we would slow down the path. Severe substance use, psychosis, severe mental health problems that really inhibit this child or this youth from engaging in consistent care, whether that be mental health care or the medical care they're going to need to stay engaged in. And rarely do I say things are at that severe a level. And certainly mental health conditions that are limiting that child's ability for informed assent to the treatment. So if they're actively using substances and their ability to like really weigh risk and benefits is compromised, or they're actively psychotic and really can't, that's interfering with their capacity for assent, you're definitely going to need to slow things down. You certainly want to slow things down for youth who are questioning or who really present inconsistently with their gender identity. And that's very rare, but I do see some youth with some complex trauma with very limited sort of ego formation that have really no consistent gender identity ever and don't really present with gender dysphoria. I often slow things down for youth on the autistic spectrum just because they're often concrete thinking, and we kind of have to slow down also the social impacts of their transition because they have some more social limitations. And finally, really supporting caregiver and environmental. I really slow things down when there's limited family support, or this is the worst, the arguments between caregivers. So one caregiver agrees that the kid needs the hormones and the other caregiver disagrees. You definitely need to slow it down, because if they're both share guardianship, then they both have to agree to the interventions. And that often involves legal help, case management, extensive family therapy, and those are probably the most burdensome cases to take care of. Behavioral health would be ideal in a multidisciplinary care model, but I know all of us don't exist in that. So really, you can practice different models of care, the multidisciplinary setting where you could get supported by behavioral health, but you can also refer out or get creative and sometimes just use behavioral health as consultation briefly and not always have multiple interventions, like weekly standard interventions. I'm going to close now just to leave enough time for questions. I really appreciate y'all's patience, and I kind of took us up close to the hour, but I'm very open to any questions that anyone might have.
And please feel free to use the chat box. I do have us opened up here so you can speak. But I do apologize, we cannot get the graphic back up. Our network is not working correctly right at the moment, and I'm trying to figure out what's going on, but I hate to reboot something at this point.
I'll confirm that everyone can still hear.
Can we still hear everybody?
Can you let us know and confirm that we can still hear the presentation?
We have a yep.
We have a yep. Okay. Excellent.
I can hear, yes. Okay.
Hi, Blanca.
Thank you all for hanging on.
Hey.
Hi there.
So I can't see if there's questions on the chat. Okay.
No questions so far.
Okay. So, Dr. Sharon, I had a question.
Oh, yeah, sure.
I think overall this was an excellent presentation, so thank you for this information. As a behavioral health provider, when someone's referred to your clinic or you're giving a referral out, what's the typical length of treatment? If you're going to, I know of course it depends on the complexity of the case and what the issues are, but is there a typical amount of time that you sense that these cases take in terms of the time commitment?
It really varies. There are some kids that I see that are these just slam dunk kids, super supportive family system, super supportive school system, really supportive community. Often those kids are the ones that have socially transitioned already without ever even seeing a provider. They've already been living in their affirmed gender, and parents and kids are like very easy to diagnose gender dysphoria, not a lot of other co-occurring mental health issues that are complicating the situation. And in that case, I might see them for 1 or 2 assessments. I'll recommend that even though everything's super keen and awesome, that the youth see a therapist throughout their gender transition, just because stuff comes up.
So support.
But not necessarily need. So I might see them for 1 or 2 assessments. And if they're like, no, I don't really need a therapist, everything's going great, then I'll maybe see them every 3 to 6 months for monitoring to ensure that the interventions are going well, that every other aspect of that child's development is going well. And then also continue to sort of bring to mind issues that they may want therapy for, like dating. Dating as a transgender kid, it can be really challenging and difficult to navigate, or social media and putting one's transition up on social media and all the challenges that can bring up. But then there's cases where I've got a split family system, they share guardianship, they're in constant disagreement, the kid's got autism, ADHD, severe externalized behavioral dysregulation, some co-occurring substance use, and some risky behaviors. And those cases I might be working with on a year before we ever get to really a referral towards hormones or physical intervention. So it's a snowflake kind of situation, and it's hard to say. But I would say if you follow those kind of goals of care, know your role, it can be a lot easier to sort out what the level of need is going to be.
Okay, thank you. And you had mentioned that it's mandated in children that there's a behavioral assessment before hormone therapy is initiated. What's the mandate for treatment throughout hormone replacement?
So they recommend that the youth stay in individual therapy. It's not mandated, but it's recommended. What is mandated is that behavioral health assessment, and there's still a lot of controversy over this. I'm going to US PATH. The WPATH is an international organization. US PATH is stateside, specific to trans health, and they have their first national conference in LA tomorrow. And I'll be going there, and there's going to be a lot of debate over behavioral health's role in terms of, does behavioral health's role with these youth increase stigmatization, increase marginalization, create more barriers to accessing care? And I would say in this state, I've seen that. And I've also seen pediatricians and endocrinologists that have started youth on hormones prior to any behavioral health assessment or without one, just because there was no behavioral health to be found that could take care of these youth, which is why I really emphasize for behavioral health here today that if they don't have the experience or the knowledge, well, how do you get experience? You do. So don't turn the kid away, you know, increase your knowledge. WPATH has some great educational initiatives going out. And for about $600, you can go for a weekend and get a lot of excellent training in behavioral health to take care of these kids. So there's, you know, there are things that you can do to increase your knowledge base. And I would say for the youth I've seen where the pediatrician or endocrinologist has started the hormones without ever even consulting in behavioral health, some youth have been those slam dunk cases and gone on to thrive and shine. And then I've seen some youth who have discontinued the treatments after 4 or 5 months because really they didn't really get that full informed consent. Those cases probably needed to be slowed down because of a few factors like autism. And that's where behavioral health's role can really like come in and shine, to really support the pediatrician or support the endocrinologist out there that, you know, knows the simple basics of, yeah, it's easy to start estrogen and spironolactone in a 16-year-old, but how easy is it to kind of ascertain, will that put that youth at risk of dropping out of school and then, or getting kicked out of the home? And those are the things that often we can slow things down and, you know, look under a magnifying glass a little bit closer to enhance the protective factors of these youth.
Excellent. Kevin, how are we doing?